lower quartile levels of testosterone, but still in the normal range, but do have symptoms? And what's your opinion on that?
That's a very good question. If you ask my personal opinion, I do put them on testosterone replacement therapy, but I'm also a guidelines panel member, and in the guidelines panel member, we explicitly indicate that we are not supposed to do that. But sometimes science is coming behind the clinical practice. I have many patients who are showing excellent results after I put them testosterone replacement therapy, although their testosterone levels were not below 12. But also I see a lot of patients who are not seeing any benefits. So instead of doing all the diagnostic workup and then giving the treatment, I use treatment as a kind of diagnostic tool. If he's happy with testosterone replacement therapy, if he is deciding that, if he knows, if he's aware of the risks and benefits, and if he wants to do it, I do prescribe.
So there are a couple of follow-up questions. Is that a follow-up question to that? No, I'm sorry, I just have a follow-up question, and you ask your question after, yeah. Okay?
Again, from Glasgow, I'm from Libya at the same time. So when you do a PSA, usually I have trouble with the patient taking testosterone therapy. The PSA start fluctuating, and then the patient become very anxious, and then we do an MRI, and then you go into the cycle, PSA density high, you got biopsy, came back low-grade prostate cancer, you stuff, and then you say to the patient, look, you take your testosterone, you can't live, you need the muscle, you need the activity. If the patient had his family, was there any guideline that could, if he has his family, everything, he could have prostatectomy, and then he could have, what do you do, and how the PSA, how far you do it when he takes his pellets from the testosterone?
The association between testosterone and prostate cancer has been put to our books, our holy books, in 1946 by a guy called Huggins. And then in 1964, if I'm not wrong, Huggins got the Nobel Prize for showing the association between testosterone and prostate cancer. But when we look to those papers that were published in 1940s, 50s, we are seeing that they are basically case reports. So they are not double-blind, placebo-controlled studies, and etc. Of course, I mean, there is a kind of association between testosterone, but supraphysiologic levels of testosterone can trigger prostate cancer. But if you are keeping the testosterone in the normal ranges, probably it's not triggering prostate cancer. Two studies published, actually one study with many, many papers published, Traverse trial in 2023. And the findings of those trials demonstrated that all our fears, all our concerns are not really true about testosterone treatment and prostate cancer, testosterone treatment and cardiovascular diseases. On the contrary, it's decreasing cardiovascular risks, so it is increasing the life expectancy of those patients. So I believe in a couple of years we will have more data, but at least nowadays, if a patient has controlled prostate cancer and if he's suffering from male hypogonadism symptoms, I do put them on testosterone replacement therapy, of course, under very attentive surveillance protocol.
So andrology is by far the most interesting subspecialty
Yes.
within urology, and there is a lot of controversy to a lot of things. We don't have the same evidence that we do in prostate cancer, for example.
Absolutely.
So you will hear discussions and opinions will differ. So I'll challenge some of the answers a little bit.
Please.
First of all, the Traverse trial, this is not so much of a challenge, it is just the Traverse trial didn't show any increased risk of prostate cancer, I agree. It also didn't show any increased risk of cardiovascular disease, but it did not show a protective effect. So there was a lot of discussion before then.
Correct.
Because you had all these poor retrospective trials, some showing a higher risk of cardiovascular events and some showing a lower risk of cardiovascular events with testosterone replacement therapy. The randomized trial didn't show that there was a difference, so probably that's true when you give it in the right patient. So that's one comment, and I agree with a lot of the things about prostate cancer, most likely from the data. If you don't give it to metastatic prostate cancer,
correct,
that would be a problem. But if the patient doesn't have that, it's probably not an issue, but I would strongly recommend to adhere to the guidelines as they are right now.
So do I. There's no disagreement here.
Going back just a little bit, because there was a follow-up question. I think this is clinically relevant. Do you have a lower limit or a higher limit of testosterone? If you give it testosterone to a man that's above 12 nanograms, nanomoles, do you have a higher limit? Like,
I
would you
don't.
give it to one with 20?
Of course, I mean, no, of course, not that much. I never thought about that, but probably I wouldn't give to 15 or 20
So 14.
nanomolecules, but nanomoles. But if the guy is 12.8, and if he's suffering from those issues, I mean, I do prescribe.
Okay, that's interesting, and it's difficult to see that we have specific trials addressing this.
Yes.
But there is no evidence that shows any benefit, certainly for above 12. I think we all agree on that, and then we can discuss the level of evidence. The symptoms, I think, is the issue here. The symptoms of testosterone deficiency are so unspecific.
Vague.
They did the ADAM questionnaire, so people would cross out if they had these symptoms, and the specificity of that questionnaire was like flipping a coin, okay? So if a distinguished professor like Ege is giving testosterone therapy to somebody, it's also going to have a placebo effect. So we don't necessarily know. I'm not saying you're wrong. You could be very right, and Dimitris was nodding before. I just want to challenge it a little bit.
No, you are right. It's not a challenge. I 100% agree what you are saying. And thanks for the opportunity of clarifying myself. In the TRAVERSE trial, they demonstrated that testosterone replacement therapy is associated with decreased LDL levels and controlled blood sugar and etc. So it was just controlling the risk factors of cardiovascular disease. Thanks for
Definitely, and
the
the price
opportunity.
in a young patient obviously will be infertility, for sure, right?
For sure.
And it's also going the price is also going to be that they probably will need to stay on testosterone therapy because you do lower the production themselves, right? So there is a price for these guys to pay. A question?
Yeah, so a little follow-up question. My name's Christopher Olin. I'm from the UK. Just a little question about testosterone replacement in sort of post-radical radiotherapy setting. So patients who've been treated with radical radiotherapy on androgen deprivation therapy, androgen deprivation stopped, but they don't have testosterone recovery, are terribly symptomatic, awful issues. What's your sort of inclination there in thinking about testosterone replacement in this patient cohort, if we're thinking about patients who would have been on sort of intermediate risk prostate cancer, 2 years of hormones?
He's not metastatic, right?
Not metastatic.
Biochemical recurrence, or I should say radiotherapy and androgen deprivation therapy.
So completely radically treated.
Under these circumstances, I would not, I'm brave, but not that brave. I mean, if this guy will identify any metastasis, probably people will accuse testosterone replacement therapy and the doctor who prescribed it. So in androgen deprivation therapy, I wouldn't do that. But if a guy, after radical prostatectomy, his PSA is stable for a year and he's definitely suffering from male hypogonadism issue, he's not able to satisfy his partner, and he feels very old, if he is not energetic, if he is getting weight and etc. In such cases, if the disease is under control, then I prescribe.
Okay, so in the cohort where potentially there is a risk to their testosterone being very low, with risk of fracture, risk of cardiac comorbidities, etc., you'd still be very reserved in prescribing, because
androgen deprivation therapy is not an innocent therapy. I mean, we are always saying, okay, androgen deprivation therapy in combination with radiotherapy, as if it's a miracle, but it is not. I mean, those men who are androgen deprivation therapy are suffering a lot, cardiovascular issues, needless to say, quality of life, and many other things. I'm not a big fan of this treatment, for sure, but again, when you are speaking about cancer, although it's prostate cancer, so not that lethal, then I would not be very, very careful.
Okay. Thank you.
It's a wonderful question, and it's really relevant, and we can't answer it. That's the answer, I guess.
Correct.
There's data from Memorial Sloan Kettering showing that 20%
Yes.
of these patients you're talking about, they will have long-term testosterone deficiency, and it affects the quality of life a lot. It's a difficult question.
And life expectancy.
It depends.
Typically, yeah.
Maybe less data on that, but for sure, the quality of life also matters, right? Again, that's andrology. That's why we're here. So it's a wonderful question. We're not that brave, right? But the endocrinologists at my hospital do treat these patients, and it's going well. So again, it's controversial, it's difficult. Thank you.
Thank you.